Thank you very much. I want to extend also my welcome to all of you to the Toronto Heart Center. There is no surest way of just making sure that the speaker finishes on time, but for the speaker to stand next to the food when the speaker hasn't eaten. So you can be sure that we'll try to not to make this very long. This is a topic that's obviously it's a difficult issue to manage, but I'll try to make it as practical as possible and say, well, you know, this is how I do it. Talk a little bit about guidelines, definitions. They'll say, well, this is how I do it, and then hopefully at the end we'll have time to give you a little bit of a glimpse into the future. We have a case here that was published actually in the New England Journal in 2006 as a good review article on resistant hypertension. And this is a 70-year-old woman. She has a long-standing history of hypertension. She comes to see you. Her medications are atenolol 100 milligrams daily, hydrochlorothiazide 25 milligrams daily, lisinopril, a good dose, 40 milligrams. She also takes ibuprofen, 400 twice daily for osteoarthritis. So 3 antihypertensives, atenolol at a good dose, hydrochlorothiazide at a good dose, also lisinopril at sort of the maximum dose that we would use for hypertension. Next, please. She does not smoke, she doesn't drink alcohol, she clearly has a large body mass index, and the blood pressure. So measured with the proper technique, the blood pressure was between 164 and 170 and 92 to 96 diastolic. Next, please. The heart rate is 72, so you could say, well, maybe she's not well beta blocked, but you know, we'll talk about that in a minute. So her ocular fondi showed arteriolar narrowing. There are no abdominal bruits. Her cardiac exam is unremarkable. Potassium 3.8, the creatinine 106, no microalbuminuria. So maybe we'll see if I can get you to give me some of your ideas about what would you do, or anything else you want to know. How would we approach this patient? And then you know, we'll get a little bit more into the topic, but I wanted to put a clinical case. It's a very realistic clinical case. So 3 drugs, beta blocker, ACE, and a diuretic, and the blood pressure is still 170 over 96 in a lady who's overweight, and she's also taking ibuprofen for osteoarthritis. Any suggestions as to how we would manage her? There are no wrong answers, because once you get to this point where you have 3 drugs, you know, there's no wrong answers. You have to find.
Does she have to be on ibuprofen?
Exactly. Well, you know, she is on a drug that may be contributing to that, and then obviously that's one thing that we can do. We're going to talk about that. So maybe she should be using Tylenol, arthritis or something like that. So that's one. Yeah. And in terms of her medications, antihypertensive drugs?
The first thing I would say probably is she compliant? I mean, one of the greatest issues you find is really people don't take their medication.
Absolutely.
Is she taking salt? I mean, these are the 2 items I think that I will be, before I even make that diagnosis.
Okay. Very good. Yeah, no, I mean, those are issues that we need to address, and we'll talk about them. So, you know, and they're very, very important. I'm glad you mentioned those. There's lifestyle modification, you know, diet, adherence to medications. Those are key issues. And as you will see, those are some of the reasons why people are not well controlled. Absolutely, I agree with you 100%. Any other suggestions? Okay, well, let's continue, and then maybe we can talk a little bit about this later. Pardon me? No? Okay, so these are sort of the objectives. We're going to talk about a definition of resistant hypertension. We're going to talk about other medical conditions that can contribute to a lack of a response to antihypertensive therapy. And then I like to concentrate also on this issue, a practical approach. So what's the most appropriate diuretic for a patient? If we're going to use dual renin-angiotensin system blockade, what should we use? What has evidence? What has evidence that actually is negative evidence or counterproductive evidence? And then an interesting topic, there's a lot of emerging data on the use of aldosterone antagonists, so we're going to talk about that. Next, please. So how we start by defining the terms. And it's a bit of an arbitrary definition. And we must accept that. This is the definition that is now accepted pretty much universally, that resistant hypertension is blood pressure that remains above goal in spite of the concurrent use of 3 antihypertensive agents of different classes. So this patient, she was on a beta blocker, she was on an ACE inhibitor, and she was on a diuretic. So she would meet this definition. But as we'll see, some of those agents may not have been the most appropriate for her. And there were other contributing factors, as was very well pointed out, the use of a non-steroidal anti-inflammatory drug. So next. Now, this is just a little item here to expand the definition that if a patient requires 4 drugs, and that patient is well controlled on 4 drugs, that's also resistant hypertension. So, or 5 drugs, or whatever the case may be. So, if you finally get a patient under control on 4 drugs, that's a patient that has resistant hypertension. So, this is an interesting subject. I mean, how prevalent is it? And we really don't have a very good idea. Now, there are some newer studies that are pointing to the fact that it's actually not uncommon. This is an editorial, this published Hypertension 2011, and as you can see, the title is self-explanatory, Resistant Hypertension, Bad and Getting Worse. And this is an editorial that accompanied this paper in the same issue of hypertension. And this is based on a big survey called NHANES in the US. This is a survey in which they based their guidelines and is representative of the overall US population in terms of risk factors. And based on that survey, then among drug-treated hypertensives, it's almost 13%. And this is sort of the best data, and it's data from this year. It's about 13%. If you take all hypertensives, it's about 9% of patients that are resistant. I mean, sometimes it seems like there's more than that, but that's sort of the data in the overall population. Next, please. Now, this is from the same article. Then, if they look at the types of antihypertensive medications that these patients were using, these patients with resistant hypertension, you can see the first 2 categories, ACE inhibitors, ARBs, 57%, 41%. So they're used in a very high percentage of patients, and that seems to be an appropriate thing to do. Now, beta blockers, 75%. And this patient was on a beta blocker. So this may not be the best choice. The Canadian guidelines, for instance, tell us that we shouldn't use beta blockers in people over the age of 60 because they just don't work very well. If you have to use a beta blocker for a different reason, heart failure, angina, of course you're going to use that, but not necessarily to treat hypertension. Because in most cases, in patients that are over the age of 60, it is not going to work. Calcium channel blockers, very high. It's 66% there. Now, diuretics. This is interesting. So, 58% of diuretics, and 55% that is hydrochlorothiazide, which I think sort of corresponds to our practice, or maybe we even use more hydrochlorothiazide in Canada than that. And that may be appropriate. Now, we're going to talk about some alternatives to the use of hydrochlorothiazide as part of my presentation later. Loop diuretics 30%. So that would be like furosemide. It seems a little high, and we'll talk about that as well. They may be very appropriate in certain patients with renal impairment. But the problem with diuretic like furosemide is that they're short-acting, and they tend to, thank you, Shiming, they tend to cause a little bit of a compensatory activation, sympathetic activation, renin-angiotensin system activation. So if you have to use them, you can use them. There is a long-acting loop diuretic in the States called torsemide, which we don't have. But generally, if you have to use a loop diuretic in a hypertensive patient, you're probably going to have to use it twice a day. Look at the aldosterone antagonist, only 3%. And I want to make a case today that maybe we should be using that more often. And then other categories, alpha-adrenergic and centrally acting and direct vasodilators, they're all used in smaller percentages. Next. Now, and something else that tells us that, that perhaps 12%, 13% is sort of the minimum, is that in clinical trials, and these are patients that are very well taken care of in clinical trials, they're seen very often. They try to make sure that the patients are complying with the medications. And in clinical trials, there's a number of good clinical trials here, between 20 and 35% of the patients could not achieve blood pressure control, despite receiving more than three drugs. So it's, I would say 13%, 12% is probably a minimum, but it may be even higher than that. And as the editorial suggests, getting worse. Next, please. So, what are the characteristics that are associated with resistant hypertension with older patients? Obesity, excessive dietary salt ingestion, chronic kidney disease is a big one, diabetes, the presence of left ventricular hypertrophy, black ray. So in the United States, in African Americans, that is a very significant problem. And then, interestingly, this is American data, living in the southeastern United States, and that may have something to do with diet and salt and the grits and all of this with lots of salt. Next. Okay. Now we have to make sure that the patient doesn't have pseudo-resistant hypertension, and we could make a case that perhaps that patient that I presented at the beginning may have pseudo-resistant hypertension because this is lack of blood pressure control, but the patient doesn't truly have resistant hypertension. Next. And it could be from a number of things. It could be because we're not measuring the blood pressure properly. It could be because of the white coat effect. That's a big one. Or poor patient adherence. That's exactly what you were mentioning here, right? And that can be because complicated dosing schedules, because costs are, and especially in the younger patients in our country, cost is an issue if they don't have insurance. It could be because we're using inappropriate combinations. And again, in that patient, well, using a beta blocker was probably not a very good idea. She's 70, and probably the beta blocker is not going to be a very good agent for that patient. She doesn't have heart failure, she doesn't have angina, then probably using a beta blocker wasn't very good. And this one I think we're all guilty of a little bit, because the patients always tell us, when they're not a target, they always have an excuse. Often they have an excuse, I had to rush this morning, and that's probably why it's high. And we said, yeah, you're probably right. Well, we'll check it next time. I mean, it happens to me. So I know that sometimes we don't want to challenge the patient a little bit more and say, no, you have to increase the dose, or we have to add another agent. So there's a little bit of inertia on our part sometimes. Next. So this is important, how to measure blood pressure properly, because there are instances of resistant hypertension that the reason is that we're not using the proper technique. So next. Next. Okay, so these are two of the most common mistakes. So if we use a cuff that's very, very small. So the cuff has to be, the bladder in the cuff has to be at least 2/3 of the circumference of the arm. So if we use something that's very, very small, that would give you a falsely elevated value. And also, if you measure the patient with measure the pressures without allowing the patient to sit and relax for a little bit, and we'll talk a little bit more about that. This is probably a common clinical problem. So we don't know. We don't have a good idea of how common it is, but it's probably a common clinical problem. Okay, so this is from the Canadian Hypertension Education Program. These are the Canadian guidelines, and this is you can find this online, and you can download it. So this is the ideal situation. So the patient shouldn't have any coffee, any caffeine in the preceding hour, no smoking in the preceding 15 or 30 minutes. Try to make sure that they're not using other adrenergic stimulants. This is an important one. I've had patients that are very hypertensive, and then and in the previous visit, they were not hypertensive, and they're taking the medications, and it's because they've been waiting in the waiting room, and then they got called, and they put in the examining room, and they had to go to the bathroom, and they didn't want to tell anybody because they were afraid they had to wait longer if they missed their chance. They missed their chance to be seen. So if a patient is uncomfortable, the blood pressure is going to go up. So quiet environment, etc., etc. And patients should stay silent prior to the procedure. Patients sometimes they're very chatty and they want to talk all the time. And so what I do here and at St. Michael's, I use 2 examining rooms. So I make sure that I sit them in one of the rooms, especially if it's a hypertensive patient that I know it's difficult to control and all that. I bring him into the room, have him sit there, and I go and see the other patient. And then once the patient is sat there, I use an automated blood pressure cuff. And then I put it around the arm and make sure that they're properly seated, like this gentleman here. You see his arm at the cuff at the level of the heart. The legs are not crossed. He's comfortable. He's sitting up. His back is supported. Then I turn the machine on and program it to do a certain number of readings, a minimum of 3, at least 1 minute in between. You can program it for 2 minutes in between, and then I go and see another patient.
What kind of blood pressure cuff do you use yourself?
The one we have here is BP True. At St. Michael's, we have an Omron. It's an Omron device.
There's no way that you can calibrate these machines, can you?
No, well, I have asked that from Omron. In the case of the ones at St. Michael's, they said they're calibrated for life. That's what they told me. But they also said that if I had serious concerns about one of these devices not working properly because I was able to show some discrepancy, that then I could send it to them. But there is no routine calibration that is necessary. Yeah. Excellent question. Next. Okay, so the white coat effect. So white coat effect is a significant problem. And there are some studies that suggest up to 25% of the patients who are referred for resistant hypertension really at a target when ambulatory measurements are performed. Now, ambulatory blood pressure monitors, this is probably the #1 indication. Unfortunately, as you know, they're not covered. I mean, we do them here. They're not covered by OHIP. I think eventually they'll have to be covered because in the UK, for instance, there's been a recent recommendation to pay for ambulatory blood pressure monitoring because of this indication, the possibility of white coat hypertension. Because I figure that the way they look at it is it could save the system money by not putting patients on more medications that they don't need. So there has to be an economic calculation there, but the UK has already recommended coverage for ambulatory blood pressure monitors for the indication of rural white coat effect. Next, adherence. That's what you were talking about, right? This is a very significant issue. So, and the studies are not encouraging when you look at it. I mean, 40% of newly diagnosed hypertensive patients will stop their medication during the first year. Only 40% of the remaining will continue therapy over the next decade. If you look at almost 5,000 patients enrolled in phase 4 clinical trials, you see that within a year, 50%. So this is very consistent. All of the different studies, people stop taking their pills. So what can we do? I mean, it's a difficult subject, and so one is, well, let's try and use agents that have few side effects, and I think we are now very lucky because we do have agents that have a very good side effect profile. Some of you have been in practice for a long time, probably remember some of the older agents that, yeah, they lower blood pressure, but the patients just could not take them because they were pretty terrible in terms of the side effects. So once daily, if possible, but twice daily the most, but once daily if possible, and then fix those combinations. And that's good because you're getting 2 drugs in there for just with 1 pill. I cannot tell you how important this is. One of the things I dread the most is when I see a hypertensive patient comes in with the diagnosis of resistant hypertension, and I tell them, well, what are you taking? They take a plastic bag here from a plastic bag from Metro and put it on the desk, and there are, well, all those these bottles of medications and vitamins and all that, and just there's no way that someone who's taking 10 medications, they have to do that every day. I'm sure that they're missing their medication from time to time. And I had a patient at St. Michael's, a Spanish-speaking lady, that her blood pressure was 198 over 106, 198 over 110, despite multiple medications. And then, it occurred to me, well, there has to be an issue here because I can't believe that this was a tiny lady that I can get her under control. So I wrote on her prescription blister packs. Next time she comes, 128 over 70. So, sometimes those are the kinds of things. If you really suspect that the issue is adherence, well, tell them, get one of those pill box organizers, prepare your medications weekly, do it this way, or you tell their family members about that, or use blister packs. So this, of course, helps, right? To explain to them. I mean, sometimes they don't know why they have to have their hypertension treated, and so putting a little bit of the fear and God in them, tell them, well, look, I mean, stroke is a terrible thing, and heart failure and a heart attack, and you want to be paralyzed. Well, I'm sure you don't want to be paralyzed. So sometimes they don't understand that hypertension can cause these things, and since it doesn't hurt them, they don't think that taking the medications is important. Okay, now this is kind of difficult to see in a small screen, but these are sort of the factors, many factors that contribute to resistant hypertension. At the top of the list, you may not see it, but this is non-steroidal anti-inflammatory drugs, and we had that case. Decongestants we talk about, cocaine, amphetamines, oral contraceptives in younger patients, licorice. That sometimes we see that occasionally, not too often. Alcohol intake, excess sodium intake, obesity, we talked about that, diabetes, etc., etc. There are a number of identifiable causes of hypertension. Some of them, of course, are very uncommon, like pheochromocytoma, and others. Others are more common, like chronic kidney disease or sleep apnea. So here I divided them in that way. So the common things, sleep apnea. So if you have a tough patient, difficult to control, and you think that sort of fits the profile of a patient who could have with a risk for obstructive sleep apnea, well, screen them for that. Ask them, all the usual questions about snoring and daytime sleepiness and non-refreshing sleep and et cetera, because that's a common issue. Chronic kidney disease, we talked about that. Renal artery stenosis is probably not as common as sleep apnea or chronic kidney disease. Aldosteronism is interesting because I think we sort of underappreciate how many patients are out there with aldosteronism. And I'm not talking about the big adrenal tumors, or I'm not talking about that, but more of increased adrenal activity. And then, of course, these are all very uncommon. And if you're suspecting any of these, well, refer the patient to a specialized clinic, of course. Salt. So that's a big one, right? We have to make sure that we tell patients about this, that we talk to patients about this. There are patients that are very salt sensitive. So the elderly. Black patients or patients with chronic kidney disease. Those patients are very, very salt sensitive, and they're going to be very difficult to control without using a diuretic. So how common is this problem? Well, probably fairly common. Here's a study in a university hypertension center. This is also in the US. Patients referred for resistant hypertension. It's hard to believe because the recommendation, well, this is 1,700 milligrams of sodium, 2 grams of sodium. And in these patients, they did 24-hour urinary sodium excretion, and the average dietary salt ingestion exceeded 10 grams a day. So I don't know what they were eating, but 10 grams a day. And there is a lot of sodium that the patients don't know is sodium. The Chinese population, we see some of those patients here, soy sauce, right? Do you know how much salt, how much sodium is there in 1 tablespoonful of soy sauce? The red cap, not that I'm talking about the low, the green cap. Any idea?
3,000 milligrams.
Well, a little bit of 900, right? 900. So I mean, you eat two tablespoonfuls of that. That's your daily allowance of sodium, and even the green cap one that that we like because it's low sodium. That's 600. There's still a lot of sodium there. So this is another. So look for sleep apnea and talk about sodium and talk about adherence. Next, obesity. I mean, it's obviously a very difficult issue, but it's clear that if patients are obese, that is going to cause a number of problems that will make it more difficult to control their hypertension. And so obese patients have impaired sodium excretion, they have increased sympathetic nervous system activity, and there is a renin-angiotensin-aldosterone system upregulation also. Especially visceral fat. I'm sure that you've heard about how visceral fat is really metabolically very active, right? That it's not just a deposit of adipose cells. A lot of bad things are made there, and this is why we talk about the metabolic syndrome and all that, because it's metabolically very active, the visceral adiposity. Sleep apnea, we talked about that already. We said, well, untreated obstructive sleep apnea is a big issue in resistant hypertension, and also normotensive patients who have undiagnosed obstructive sleep apnea are more likely to develop sleep apnea, who don't have sleep apnea. So those patients, sorry, let me take one step back. Normotensive patients who have obstructive sleep apnea are more likely to develop hypertension in the future. So it's clearly a risk factor. And the more severe the sleep apnea, the less likely it is that the blood pressure will be controlled despite good medications. And next. So this, I talked about this. So we're not talking about a big adrenal tumor. We're talking about the hyperactivity of the adrenal glands. This is probably an important problem that we just haven't recognized, but it is probably a very frequent problem, and probably it's increasing because of obesity. Remember, we're talking about increase of the renin-angiotensin-aldosterone system with obesity, probably from the different factors that are made by those visceral adipocytes. It's one of the hypotheses as to why we're seeing more of this hyperaldosteronism. Now, this is surprising, and it's been surprising to me that, of course, I've seen patients who have a low potassium that they're seen in the emergency room with a hypertensive crisis, and they have a low potassium, and they don't have a very good reason to have a very low potassium because they're not on diuretics, of course, those patients, they're relatively easier to diagnose. But a lot of these cases of hyperaldosteronism, the potassium is normal. And the way they explain this is that hypokalemia is probably a late manifestation of the disease. So when you get there, then it's not so difficult to diagnose it. Now, do we have to do any sophisticated imaging? No, I mean, we don't have to be doing any sophisticated imaging for the most part, or any very sophisticated endocrine testing, because, and when we get to the practical aspects of how we manage it, I'll tell you how we can just use an aldosterone inhibitor and try it, and it will work, even if the aldosterone renin ratio and other things are not necessarily elevated. So we don't have to get fancy with imaging or sophisticated endocrine testing. If we have a patient that's not well controlled with 3 drugs, we can make a very good case that we're going to try an aldosterone antagonist. Okay, so what do? We have to confirm that there is treatment resistance. We talked about the definition. We talked about pseudo-resistance. We're going to exclude pseudo-resistance. So Y code, adherence, etc., etc. We're going to talk about possible reversible lifestyle factors: obesity, physical inactivity, alcohol, high salt. So this kind of summarizes what I've been showing you already. We're going to discontinue, right, some interfering substances, like this lady that we talked about, the non-steroidal anti-inflammatory agents. We're going to look them for those secondary causes that we were talking about. Some of them very, very unusual, and better to refer the patient obviously to specialized clinic for that. But sleep apnea, so snoring, witness apnea, daytime sleepiness, the things that we're talking about. Primary aldosteronism. I mean, you can get aldosterone and renin levels and get a ratio, etc. But as I will mention, that's not always necessary. Chronic kidney disease, and then the more unusual causes. So now, this is important. Then how do we start approaching the management of this? We have to make sure that we're using the right doses of diuretics and start using the right diuretic. So people say, well, if your 3 drugs don't include a diuretic, you can say that that patient is resistant. So, but that's not the official definition. The official definition is any three drugs from different classes. But a diuretic, as one of those 3 drugs, it's always important. So now, I was talking about this. I mentioned it already. Sometimes you have to use loop diuretics in patients with chronic kidney disease. Next. So diuretics. If you look at clinics that manage resistant hypertension, quite often they find that this is a problem. Patients are not using diuretics, or they're not using the right type of diuretics. So there are patients that are very, very difficult. Those salt-sensitive patients that we talked about can be very difficult to control without a diuretic. So here's a tip, practical tip. Creatinine clearance less than 30, use a loop diuretic. It's not ideal in patients with better renal function for the issue that we were talking about, shorter acting, et cetera, but those patients are not going to respond well to a thiazide. So just a little, the cardiologist simplified view of the kidney, but that's a glomerulus there and the tubules. But the important thing is, see, the loop is 25% of the sodium gets reabsorbed in the loop of Henle, and only 5% in the distal tubule where the thiazides act. So if you have decreased GFR, so you're going to have even less sodium being excreted. By the time that sodium gets up here, a lot of it, see 65, 70% there, 25% here, a lot of it is already going to be reabsorbed. So that's a kind of a simplified way of thinking. Low GFR, so lower glomerular filtration, less sodium, and then it will go through areas of high absorption, and by the time it gets here, where the thiazides work, there will be very little left. Next. So now, which diuretics? Okay, so we use a lot of hydrochlorothiazide. I mean, it's not a bad drug. Bit of a shorter half-life, 9 to 10 hours. I particularly like, and I would encourage you to use more chlorthalidone. Several reasons. It was the diuretic that was used in the major clinical trials, like the systolic hypertension in the elderly project, like all had. So the major US clinical trials that demonstrated that diuretics were good to lower blood pressure, they used chlorthalidone. They did not use hydrochlorothiazide. It's more potent, and I'll show you how it also works at lower eGFRs than hydrochlorothiazide. Additional advantage of chlorthalidone, look at the half-life. So if patients forget a dose, it's not such a big deal with this. Why is it so long? Because it binds the carbonic anhydrase in the erythrocyte. So it creates a reservoir in the red blood cells. And it seeps out of the red blood cells continuously. So you get action throughout the 24 hours. Interestingly, I have a number of patients, and my nephrology colleagues at St. Michael's do the same thing, that are well controlled on 25 or chlorthalidone Monday, Wednesday, Friday. You don't even have to use it daily. If you find that they're getting a bit dry when you use it daily, that the creatinine has gone up, and that the potassium may have dropped a little bit too much, well, you can try it on Monday, Wednesday, Friday, 25 milligrams, because with such a long half-life, it works quite well. So I tend to switch a lot of patients who are already on chlorthalidone, on hydrochlorothiazide, good doses. I tend to switch them to chlorthalidone.
I seem to recall that maybe 30 or so years ago, chlorthalidone was pretty commonly used, and it's sort of just drifted. Was that the wrong word to use? Chlorthalidone was there something bad about it?
No. I mean, it's a very good point. There is a disadvantage to it that is, well, we don't have a lot of fixed dose combinations, right? You can have the irbesartan with hydrochlorothiazide. You can find ACEs with hydrochlorothiazide. We don't have. I think there is a combination with atenolol. I think there is a fixed dose combination in Canada with atenolol, but I mean, I wouldn't necessarily recommend atenolol for management of resistant hypertensive patients. Yeah, it's one of those drugs that I think is underutilized, and the evidence is there. The trials, I mean, all had big trial, 4 different classes, diuretics very good in lowering risk, and it was chlorthalidone that was used. So it's a very good drug. Okay.
What dose do you use?
Pardon me?
What dose?
I usually may start with 12.5 once daily. May go up to 25. I rarely go up to 50. You get into a lot more hypokalemia and other things once you start getting up there. But as I said, there are patients with 25 Monday, Wednesday, Friday, and that's enough. So now there are studies that have compared both drugs on ambulatory blood pressure monitoring, and chlorthalidone is here in these clear triangles here, and you can see that it is clearly more effective. This is a randomized trial, and you can see that it is more effective. And next, and particularly for nighttime mean blood pressure in ambulatory monitoring. So it's a relatively small study. It was published about 5 years ago. But if you look at the 24-hour average blood pressure, there was a trend in favor of chlorthalidone. So it lowered blood pressure by 12.4 millimeters of mercury, supposed to 7.4 for hydrochlorothiazide, but it failed to achieve statistical significance. If you look at the daytime mean, then there was no, I mean, the trend was there, and maybe the study was underpowered, but it did not achieve significance because during the day, well, they're both active. But look at the nighttime mean. Then it was twice as much blood pressure reduction those are big numbers for ambulatory studies. Next. Okay, and this is now getting to that what I was telling you about the aldosteronism. So this seems to be a common problem in patients with resistant hypertension, and there's a number of studies that have been showing lately that inhibiting the mineralocorticoid receptor, and spironolactone is obviously the one that we have here in Canada. As you can see, I mean, these are all generic drugs. So this is part of what we want to do in our center here is, we're giving you what we think is the best possible advice without commercial biases. I mean, these are chlorthalidone is pennies, and spironolactone is also very inexpensive. Next, and this is a study that looked at low dose between 12.5 and 25 milligrams of spironolactone in subjects with resistant hypertension, showing the systolic and the diastolic blood pressure reduction. These are patients that were already, this is not like double-blind, placebo-controlled, etc., etc. So this is one of the older trials, perhaps not such a great trial because it is not placebo-controlled. But you can see the big drops that you can get in some patients when you add spironolactone. I have seen patients that have had this kind of response. I have to say, not all patients will have this kind of response, but I have seen patients that, that 20/10 is what I see. So you see this kind of drop with 25 milligrams of spironolactone. Let's go to the next. We can. This one basically said, well, maybe we'll make a quick point here, that these patients were treated with an average of 4 medications, and you see the blood pressure response was not necessarily predicted by the baseline plasma aldosterone or by the 24-hour urine aldosterone. So it's not necessary to do all this fancy testing because they seem not to be predictive of whether a patient is going to respond or not. Once you have a patient on 3 drugs, this could be a good 4th-line drug, and you don't have to do other fancy testing.
So you are saying trial and error. If it works, then you. If
it works, you're good. Yeah. If it works, you're good. Yeah. Then you have to keep looking at why the patients. But you'll be surprised. Give it a try, and I think you'll be very happy. Okay. Now, This study, this is a better trial. I don't know if you remember the ASCOT study. The ASCOT study, they compared amlodipine perindopril, so sort of the newer generation antihypertensive drugs, with beta blocker thiazide. And they showed that a treatment based on amlodipine perindopril was better in terms of prevention of events than beta blocker and hydrochlorothiazide. They could add other drugs on top of these two combinations if the blood pressure was not well controlled. They could add diuretics. They could add vasodilators, etc., etc. So they had a number of patients, about 1,200 patients in ASCOT, who received spironolactone as a fourth-line drug. It was a big study. So there are about 1,200 patients who received spironolactone as a fourth-line drug. And as you can see, the drop in systolic blood pressure was 22 millimeters of mercury. And diastolic, it was almost 10 millimeters of mercury. So it's not unusual. Sometimes you do see these big responses. And this is a very good clinical trial. And the next, I wanted to present to you the most recent data. This was just presented at the European Society of Cardiology in Paris. I was at that meeting at the end of August, beginning of September, so about a month ago. And this is a properly done, randomized, placebo-controlled trial specifically to test spironolactone in patients who were on 4 to 5 drugs already. And the numbers here are for ambulatory blood pressure monitoring and office blood pressure monitoring. As you can see, numbers of 11, 14, 14 and a half for systolic blood pressure. Those are very good numbers in a very well conducted study. So that sort of give you what I wanted to tell you about the aldosterone antagonist. Now, here's the take-home point, my practical approach. Okay, so now, and it's based on the evidence. I'll show you all that a little bit. The best combination to prevent cardiovascular events, and this is being shown now in good clinical trials, is an inhibitor of the renin-angiotensin-aldosterone system, be it an ACE or an ARB. I tend to prefer to start with an ACE because there's a bit more evidence, but if the patient doesn't tolerate it, then we can use an ARB. And the hydropyridine calcium channel blockers, so nifedipine and amlodipine. So that is the best combination. Those are generally my first two agents, unless there is a compelling indication to use something else, as I said, angina or heart failure, etc., etc. So that's usually my. And what do I use? I tend to use agents that give me a good 24-hour blood pressure reduction. So I prefer agents that have a higher trough-to-peak ratio. I like phendopril because that's the highest, but ramipril is not bad. Perindopril I use also. I tend not to use the ones down here because they're not very good once-a-day agents. Now, why did I say that the best combination to prevent cardiovascular events is a calcium channel blocker and an ACE inhibitor? Well, we used to think that all you have to do is lower blood pressure, and that's what prevents events. And to a large degree, that is true. So lowering blood pressure is the most important thing. But the big question for a long time was, does it make a difference what you used? And that really wasn't answered until last year by this study called the ACCOMPLISH trial. Because the patients were randomized to benazepril and ACE inhibitor and amlodipine B plus A right here, or benazepril plus hydrochlorothiazide in the solid line. And there was a very significant reduction in cardiovascular events in non-diabetic patients, in diabetic patients, even more impressive 23% reduction in high-risk diabetics with very similar blood pressure reduction. So it does seem like it matters. The first thing continues to be lower blood pressure, but it does seem like it matters what you use. So a blocker of the renin-angiotensin system, be it an ACE or an ARB, and a dihydropyridine calcium channel blocker, that for that reason, that's my favorite initial two-drug combination. So now, then I get to this point here where I say, well, I may not be able to control the blood pressure without a diuretic, especially in those groups that we were talking about. So diuretic, that's my third agent. I use either hydrochlorothiazide or chlorthalidone if the GFR is greater than 60. I prefer to use chlorthalidone because it's a stronger diuretic if the GFR is between 30, 40, up to about 59 or so. Or even if patient has normal eGFR, but the blood pressure is not well controlled on 25 of hydrochlorothiazide. That's what I was telling you, that sometimes I switch the patient from hydrochlorothiazide to chlorthalidone. And loop diuretic, to emphasize, for the patients with more severe renal impairment, you have to use a loop diuretic. Next. Now, as a fourth line drug, then now you're convinced this patient has resistant hypertension. We got to the point that we use 3 drugs, and we've addressed all the other problems of adherence and ruled out the sleep apnea and excessive alcohol intake and interfering drugs, etc., etc. So this is a genuine article. This patient has resistant hypertension. So my fourth line, I always consider adding a second inhibitor of the renin-angiotensin-aldosterone system. Now, very important, no evidence for combining ACE and ARBs. We did that some time ago. We thought that may work. The fact is that one of the trials on which that was based, it's a trial called Benedict and was published in the Lancet, was just retracted by the Lancet because of some scientific misconduct on the part of the investigators. So we have no evidence for the combination of ACE and an ARB. So usually, then what I do is add low dose of spironolactone, maybe up to 25 milligrams once daily. I've gone up to 50 in some cases. You start getting a little bit more side effects, right? Gynecomastia, breast tenderness, other things when you go to higher doses. So I usually add a low dose. Now, of course, you have to follow the potassium. So especially if the patient has some renal impairment, or in that case, if you're not comfortable, then you can refer the patient to a specialist. I put aliskiren there because I've had some good experiences with it, but there is no data. But there have been some experiences in my practice where aliskiren has worked, but that's not. I usually tend to go with spironolactone. There are good trials in this specific population, and it is a very cheap drug. Okay, so that's the practical. So combine ACE or ARB with calcium channel blocker, dihydropyridine, add the appropriate diuretic, and if you still need something else, try spironolactone. So that's the take-home message. Now, a little bit of the future. This is also from the European Society of Cardiology Congress in Paris, because I think this is a very, very exciting area. What about device therapy for resistant hypertension? It's coming. So, show you very quickly. Percutaneous renal denervation. So, you see all these nerves here? All the sympathetics to the kidney? They run along the renal arteries. They have now designed devices that through radiofrequency ablation can ablate all of those nerves. And the device is going through the regulatory process in Canada. And I met with the people of this company and with some of the investigators in Australia and in Germany. And I'm hoping I can go in February of next year to Frankfurt to a course to try and learn this thing. I already do coronary angiography. I sometimes do renal angiography, so hopefully it wouldn't be too difficult for us to bring that to Canada in the future. We're trying to get, there are a number of clinical trials that are going on. And why is this very exciting? This is a great paper, Henry Krum from Melbourne, Australia, in Circulation this year. Why is this so exciting? Because look at 1 month. These are all patients with resistant hypertension, 4 or 5 drugs. And of course, we could say, well, maybe they're not compliant with the therapy. And that's true, but we will always have those patients. We will always have those patients that we have on 4 drugs or 5 drugs that, we cannot control them, and maybe one reason is compliance. If you can do a procedure that lowers the blood pressure, then that's going to help them. So see, look at 1 month, systolic and diastolic, 14/10. At 12 months, 27/17. And the next, this is a smaller trial, and this is a bigger trial. This is 1,500 individuals, and a longer follow-up, 18 months. At 18 months, 27/15 in patients who already were taking, as I said, 4 or 5 drugs. So very, very promising approach. And the last, yes?
Are they off all the medication?
Oh, no. This is like on top of the, yes, yeah. They're not a target. And then, and of course, the question always comes up, is it lack of compliance, etc. So, but the fact is, as I said, we'll always have patients who are difficult. And this is very, very interesting. This is an idea that's been sort of resurrected from the 1960s when there were some studies looking at receptor, carotid receptor stimulation for patients with intractable angina, that before coronary bypass. We couldn't offer them anything. So there were studies where they put in sort of a pacemaker, if you will, that stimulated the beta receptors. Then heart rate comes down, blood pressure comes down. The patient would press a button when they had angina, and heart rate comes down, blood pressure comes down, and the angina gets better. So of course, I mean, when coronary bypass came around, that really wasn't necessary anymore. But now it's been resurrected for resistant hypertension. So you see a pulse generator is like a little pacemaker, and it's implanted in the carotid sinus, and you program it, and you're stimulating beta receptors, and obviously it has effects on the heart, the blood vessels, heart rate, blood pressure. It has direct effects on the kidneys also, or via the central nervous system. The device is called the RIOS system, and it's made by a company called CVRX. And look at the results that they're getting in the trials. In patients with resistant hypertension, 1, 2, 3 years. Systolic and diastolic, 38/25 with these devices. So very exciting. Lots of new things happening. Of course, this has to be tested in longer clinical trials and all that. But it may be that we are going to be going from the era of relying only on pharmacotherapy to start going into the device era of hypertension treatment. Yes, like interventional cardiology with the stents, or our colleagues in the EP service, the arrhythmia service with the ablation, and different devices, ICDs and all these kinds of things. Well, this may be a very promising avenue in the future. This is, like, as I said, hot off the press, just presented a month ago at the most recent Congress of the European Society of Cardiology, and I said, well, this is really something that I wanted just to introduce to you. We're not going to be using this, anytime soon, but very exciting developments in this area. So I hope I gave you very sort of practical talk. This is what I do, and a bit of a glimpse into the future here as well. Thank you very much for your attention.